You're listening to the Future Tech Podcast with Richard Jacobs. Future technologies such as artificial intelligence, stem cells, 3D printing, gene editing, Bitcoin, blockchain, the microbiome, quantum computing, virtual reality, and exploring space are much closer than you might think. In fact, many early versions of these technologies are in play right now, and the companies that are using these technologies are the focus of this podcast. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a thorny medical problem. Remember, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you've enjoyed the podcast, please listen, subscribe, like, and tell your friends about it. Thank you. Hello, this is Richard Jacobs with the Future Tech and Future Tech Health podcast. I have a returning guest, dentist Raphael, a dentist and an orthodontist. We spoke a couple months ago about dentistry and how it can help people with sleep issues, but we didn't go nearly enough into the mechanics of the skull and breathing and the throat and everything and how that affects sleep. So I wanted to have him back because Barry's very well spoken about this. So Barry, thanks for coming.
Well, you're welcome, Richard. It was my pleasure. I enjoyed the last conversation we had, and I know that it is a very pertinent topic because so many people have issues with sleep, and we know more about that than we ever have. Not only how important it is, but how it gets disrupted, and I think that's what we'll talk about today.
Well, I wanted to ask you structurally, what goes on with the skull, the throat, the nasal passages, and everything as you sleep, and how does that, cause people problems in sleeping?
Right. So the way I look at it is that when we're breathing, we are supposed to be able to intake air from the outside through our airway passages, preferably the nose, in through the nose, down through the back of the throat, down to the bottom of the throat into the trachea. The air should flow very smoothly. And if it does, we don't really have to make much of an effort to bring the air in. Our diaphragm, the muscle on the underside of the lungs, contracts. It pulls the bottom of the chest cavity down. It kind of creates suction, sort of like what happens when you expand a bellows. And the air gets pulled in through the nose into the lungs. You don't even have to breathe deeply. That concept is actually a little bit of a misnomer. If you're using your diaphragm, air will be distributed evenly throughout the lungs, even if you're not, you don't need to take a deep breath. The air just has to cover the whole surface of the lungs. So that's easy breathing. It doesn't cause the body any distress. Happens, freely and preferably without having to think much about it. But there are some things that happen that cause air to swirl as it passes through that upper airway. And swirling of air, which is called turbulence, also creates negative pressure. So you think about turbulence as that the negative pressure that's created on the top of airplane wings. And, when you think about it, the airplane wings are kind of tiny compared to the rest of the airplane, but the turbulence that's created there can lift that, thousands and thousands of pounds up into the air reliably. Turbulence creates a lot of negative pressure. When turbulence happens in the airway, it also creates negative pressure. And that negative pressure pulls on the sidewalls of the airway to cause them to either collapse or to flutter. Huh. So when the sidewalls of the airway flutter, it makes noise. And of course, we call that snoring. And snoring is one of the hallmarks of negative pressure or turbulence in the airway.
Good question here. So normal breathing is laminar. The air that's flowing through you is laminar.
Pretty much, yeah. Now, there's some thought that air swirls a little bit around in through the nose, that there's kind of a spinning effect through the turbinates. The turbinates are little skin-covered bones that line the inside of the nose, and that turbulence is what literally centrifuges out the dust, the particles, the pollen, the mites, the dander, all the crud that's in the air that gets filtered out, say, by your air conditioning filter, that gets filtered out by your nose. And so there's a little bit of swirling there, but still, the way the nose is built, that air should still pass through without, the sidewalls of the nose collapsing. So no negative pressure built up there particularly. So but whenever you have turbulence in the air, it makes it harder for the body to draw the air through, and that can be quite discomforting. One way to experience that is to say, keep your lips together, breathe through your nose, and then take one thumb and plug up one nostril. And as you do that, the source of the air is cut in half, and the ability for air to flow through is actually cut by the power of 4. And you can feel that sort of difficulty breathing. Another way to test it is to try to breathe through a drinking straw, or worse yet, a cocktail straw. And most people...
What would probably happen is if you're breathing through a restricted airway, is you have to make more of a mechanical muscular effort to pull the air in. You have to create a greater pressure differential. And that might, in order to do that, your airway has to narrow in order to do that.
Yes. Actually, the harder you pull, the faster the air flows, and the faster the air flows, the more negative pressure is created. You get this effect where the harder you try to breathe, the worse it gets. So many people think this is what asthma is, at least part of it. So, but nonetheless, think about how uncomfortable that is. And when you experience this discomfort, you will do anything you can to rid yourself of that discomfort, right? So when I do this exercise with people, I make them breathe through a drinking straw. Before I even finish the exercise, they take the drinking straw out of their mouth. Or if you're underwater, say, and you've got a snorkel that either gets clogged or is too small or something like that, you're not going to stay there under the water and muse about how difficult it is to breathe. Your body's going to go into a panic. And panic, of course, is the activation of the sympathetic nervous system, fight or flight, an adrenaline push to do whatever it takes, because at the end of the day, breathing is the most important thing we do moment to moment. And so we know instinctively that anything that makes it harder to breathe is going to be a threat to our survival. Of course, there's all gradations of this, right? So if someone put their hand over your face and closed off your mouth and nose, they were trying to strangle you, that threat is really serious, and you're going to start kicking, you're going to lash out, you're going to try to run, you're going to make severe maneuvers to get out of that situation so that you can survive. You only have 4 minutes to do it, maybe 3 at most, right? This is how critical it is. So, but now imagine that you're sleeping, and for some reason, and we'll talk about those reasons, you also get the idea. I say your brain gets the idea that airflow is being restricted. You're going to literally have the same kind of reaction. It may not be quite as intense. It may not be quite as visible, but your body is still going to react in a way that's going to ensure your survival. So
for instance, if you're in deep sleep, you'll be aroused out of that, probably to wakefulness, but maybe not, but at least you'll be pulled out of that deep level, or whatever level of sleep you're in, you'll be definitely aroused out of it if this happens.
That's exactly right, Richard. And a lot of people don't get fully aroused into wakefulness unless it's really bad. But they do get bumped out of those deeper levels of sleep. Level 3 sleep is where our brain shuts down and the housekeeping for the day is done. The fluids get to rinse out the byproducts of the day's thoughts and metabolism. I'm talking in a physical way, not a mental way. There are literally byproducts of metabolism in the brain that accumulate over a day's worth of thinking that have to be washed out. It's kind of like school shuts down at night and the janitor comes out and he cleans up, and then the lights come back on again in the morning and everybody gets active again. Well, there's a janitorial system in the brain called the Glymphatic System, and does a great job of cleaning out. In fact, we know that when the brain is not cleaned out properly, stuff starts to accumulate, and over the years, those accumulations severely affect brain function. So this is what's thought to be at the base of underpinning Alzheimer's and dementia and that kind of thing. So being in deep levels of sleep is very important. The problems also happen in REM sleep. That's when we're dreaming, but we're especially subject to problems because most of our muscles go completely limp. Not our diaphragm, so we can keep breathing, not our eyeballs for some unknown reason, but which is where REM gets its name. But everything else goes limp, and if muscles or skin or tone of the walls of the side of the throat get limp enough, they can close off and create your drinking straw right there while you're trying to sleep. So people are extremely susceptible to that, and people that have those have to go through those arousals. Many of them report they don't really even remember dreaming much anymore. In fact, when the situation is rectified for them, they all of a sudden report having vivid dreams for the first time in a long time.
Okay.
So those are things that happen because of turbulence, and they're at the heart. Now, there are three things that create turbulence in the airway that we'll talk about. We can talk about each one, but to summarize, they are the anatomy of the airway, it is the physiology of the airway, and it's the behavior of breathing. So we'll talk about each one a little bit. The anatomy of the airway is from the tip of the nose down to the back of the throat, or, for those who breathe through their mouth and through the mouth and so forth, to the back of the throat, down behind the soft palate, which is attached to the upper jaw, down behind the tongue, which is essentially attached to the lower jaw, and then down past the epiglottis and then to the larynx. So if there's anything in the anatomy that creates a narrowing, that narrowing will create turbulence. So think about
after the narrow, like a nozzle. I guess after the narrowing, right. The exit part is where the turbulence happens.
That's exactly right. The air speeds up, and then the turbulence happens after that, and that will pull on the sidewalls. There are measurements called the critical measurements of pressure in the throat, abbreviated as P-crit, that measure just how much pressure is required to pull the sidewalls of the throat together. And of course, you don't want to exceed P-crit, because then not only is there turbulence, but then there is a cessation of flow. And you can imagine we don't want that to happen. So those narrowing spots, they can happen in the nose. They can happen right there in the front of the nose where the nostrils are. They're often narrow nostrils, or there are collapses of the cartilages, the lateral cartilages of the nose. There can be narrowing within the nose, like the turbulence we talked about can be very large and make the airway narrow. The middle wall of the nose, called the septum, that can be bent to the side. and that makes one side of the nose much narrower. It can be swollen adenoids or tonsils. It could be a tongue that sits in the back of the throat, pretty closely to the back of the throat. And frankly, that will happen if, and this is what we talked about last time, if the jaw bones, the upper jaw bone, the lower jaw bone, if they don't grow forward enough in the face, a phenomenon that's becoming more and more common in human beings in the modern post-industrial age. If that doesn't grow forward in the face, then the space behind the jaws is necessarily smaller. So that there can be those narrowing spots there, down by the base of the tongue. It can be narrow, and there's some other anatomical problems that people can be born with that will cause collapse and so forth. So that's anatomy. And then again, when a narrowing spot occurs, the narrowing will decrease the flow of air by 16-fold. It's to the fourth power. So you don't need much of a narrowing to create a significant amount of turbulence.
Yeah.
So that's anatomy. The second thing is physiology. So physiology, by that I mean anything that creates, say, swelling, edema, or inflammation, or mucus, or say, immune reactivity, inflammation, in the airway. All those things, by making the sidewalls of the airway either thicker, fat deposits is another. Anything that makes the sidewalls thicker makes the airway smaller. And so any of these things now these things are really becoming a problem because, for instance, allergies in children as well as adults are getting more and more severe. General inflammation, you probably have had, I'm sure you've had other people on your program talking about gut health and general body inflammation and leaky gut syndrome and all that kind of stuff, where they're autoimmune.
I can tell you just very briefly my own experience. For a lot of my life, my nose was always stuffed up. Like 6 months out of the year, it was horrible. And it was only when I changed my diet and, essentially ate ketogenically that my allergies resolved like 95%. But my nose would be stuffed up all the time, and it would never have both nostrils open. At best, it would be like one nostril that would alternate,
Right.
But not at all.
So, and we're becoming more and more aware of how that affects us nutritionally and all that. But a lot of people don't really realize, especially in growing children, that having to default to mouth breathing because your nose is so stuffed up is going to change the growth trajectory of the bones. And so it becomes this cycle of bad breathing, bad bone growth without good jaw growth. The airway is gets narrower effectively, and you wind up with lifelong problems because you can't breathe well, and especially at night, it's all the worse. But then there's the third piece, and I think this one is probably the least appreciated by the people that talk about sleep, and that is the way we breathe. Because turbulence is also affected by the speed of the air and by the volume of the air. So, I mean, this is why a plane can't take off until it's going, a certain speed. It can't build up that negative pressure unless the air is flowing very fast. So if you happen to be breathing fast or hard, which frankly you will do if you're in a panic, you're going to make the problem worse, because you're going to be increasing the negative pressure and coming closer to that critical pressure. So using the diaphragm and breathing gently through the nose is the better way of breathing. But many of us breathe either faster or harder or deeper, or take in a larger volume of air per minute in a way that alone stresses the airway. And it not only creates the turbulence, but it changes the balance of oxygen and carbon dioxide. And maybe we should discuss that a little bit too, because the way we breathe not only affects the airway itself, but also affects how oxygen is delivered to all parts of our body based on the fact that carbon dioxide, which we often think of as just a waste gas, is actually a critical component in the buffering of blood. And the pH of the blood determines exactly how oxygen is transferred from the lung to hemoglobin. And then a change in pH allows hemoglobin to oxygen to jump off of hemoglobin and then perfuse into the tissues. And
so what happens if you?
This is also a concept that I don't hear very many people talking about. Even sleep physicians don't really talk about this, even though it's been in the physiology books for decades and decades. In fact, this concept was granted a Nobel Prize, I can't remember when, 1920s or something like that, to Christian Bohr. And it's described by his name, the Bohr effect, talks about the dissociation curve of oxygen off of hemoglobin. I laugh because I never thought I would have to remember the Henderson-Hasselbalch equation when I learned it in undergrad. It was just, one of those things you wanted to take the test on and forget. But it becomes very, very relevant now, because if you cannot deliver oxygen properly to the tissue, then those tissues will suffer from efficient metabolism, and this happens in every part of the body. So it is thought that there was one study looking at emergency room visits in New York City, I don't know, some years ago. And they calculated that 60% of visits to the ER in New York City at the time of the study were due to, directly or most likely indirectly, the ability of the body to deliver oxygen to various body parts. If you can't deliver oxygen to your organs, they are not going to function efficiently. If you can't deliver oxygen to your muscles, then they are going to either fatigue more easily, go into anaerobic metabolism more easily, not recover quite as fast. And finally, if you can't deliver oxygen to your brain, it will also not work as well. So you're going to have fuzziness, fogginess, or poor memory, or can't concentrate, and this and that. And so the way we breathe becomes a critical factor, not only on how air passes through, but how oxygen is getting delivered to all parts of the body. And there are only a very few people that are talking about this in sleep medicine these days, and I really think it's an issue that people have to start paying more attention to. So anatomy, physiology, and behavior. Those are the three things that cause turbulence. And so when we're talking about sleep,
in terms of breathing, though, how does someone misbehave breathing-wise? Do they just a stressed person and they tend to breathe, fast and shallow, or, do people, I don't know, do they overbreathe? I mean,
it's very correct. So one very common way of overbreathing is breathing through the mouth. So breathing through the mouth essentially is a compensation for not being able to breathe through the nose. We are born obligate nasal breathers. I mean, think about it. As babies, the first thing we're going to do is suckle on mom's breast, right? Well, you can't do that if you can't breathe through your nose. And in fact, even in babies, for the first several months of their lives, they can only breathe through their nose. There's a literal lock between the nasal passage and the mouth by an overlap of the soft palate and the epiglottis. That's actually something that's found in all other animals except for humans, and but it is found in infants. Now that lock separates the soft palate and the epiglottis separate at one point. It actually is thought to be a phenomenon that occurred when we, as animals, stood up on 2 feet and became upright, and our heads started balancing on the top of our, neck and shoulders rather than being coming straight off and so forth. And our neck started getting a little bit longer, and that separation occurred. The process is called clinirinky, the anthropologic description of it. And that separation between the soft palate and the epiglottis allowed us as humans to do 2 things. Can you guess what they are?
Breathe and eat and swallow independently.
Well, one of them, you'll be surprised to learn, is speak. The reason we can articulate is because we can force air up through the mouth and shape it with our tongue and lips and so forth. But the other thing it allowed us to do, which was sort of the curse of this all, is have sleep apnea, because it's only because the tongue can fall to the back of the throat that our tongue can get to the back of the throat to close off the airway. Isn't that interesting?
Yeah, it's an interesting trade-off.
It's an interesting trade-off, is exactly right. If we left the Garden of Eden to be able to articulate our knowledge, we also have the curse of having us have trouble sleeping and all the ramifications from that.
Yeah. So what to do? What are some of the common manifestations clinically you'll see of how people are intentionally or unintentionally hurting their sleep, and what can you do about it?
Okay, ramifications of poor sleep. Well, look at this in 2 different ways. While sleep medicine and sleep dentistry, which are fields that really are relatively new, we didn't really start paying much attention to this until the 1980s, 90s. Dentistry started jumping in a little bit after that. The thing that most people in sleep medicine, sleep dentistry are worried about is sleep apnea. Now, sleep apnea occurs when peak is reached and the airway collapses and oxygen levels start to drop in our blood. So the airflow either stops or it becomes slowed down enough that we're using oxygen out of our blood, but we're not replenishing it, and so you get a drop in blood oxygen. And these are called apneas and hypopnea. And really, this is what most people are focusing on when they go to a sleep physician. They put them in an overnight sleep study. That's what they're going to measure. How many apneas and hypopneas do you have in an hour? That's what they call their index, the average of an hour. And
what if you're not having apneas? What if you're just having have upper airway restriction, which doesn't wake you up but causes you to have arousals 1,000 times a night?
That was exactly going to be my point, Richard. I'm impressed that you picked up on that, because right now apnea is probably prevalent. They're estimating in 8 to 15% of the population, and even out of that, probably only 10% actually figure it out. But apnea and hypopnea happen largely after years and years of having trouble breathing at night and successfully averting the problem by adopting some kind of compensation while you're sleeping. So in other words, you think about that feeling again you have when you close one nostril or breathe through a drinking straw. That discomfort happens, and we do things to get rid of it. So what do? We roll over, we open our mouth, we breathe faster, we breathe harder, our heartbeat raises, sometimes 20, 25 beats per minute. These are all things that we can do to get our air going again and chill out, and then we go back to sleep. But after doing that for years and years, and the struggle and effort to breathe when it's hard to breathe, the body starts to wear out. the neurologic connections start to wear out, the muscular patterns, the muscular tone in the throat starts to decrease. And besides, our skin is getting less elastic, and we're building up more fat as we get older, and all of those things. And then finally, the body just kind of gives up. It says, look, I've been through this a million times before. It's okay if I stop breathing for 5 or 10 seconds, or even 15 seconds, or 20 seconds. And then eventually it gets so threatening that you wake up with a snort and a start, and then you take a deep breath and catch up on your breath a little bit, and then you fall back. That's classic apnea. And it's not easy to watch. It's really scary to watch.
I know, I've seen it. It's horrible.
Bed partners will look over and they'll go, "Oh my God, I thought you were dying." It's like but that's the end stage disease. And this is really important. You picked up on this, is that before you get to the point where you actually have apnea and hypopnea, you're probably struggling to breathe, but just successfully dealing with it. And so what I focus on largely in my practice is not the people that have gotten to the end of the line and have high apneas and hypopneas. I'm trying to intercept this problem for people way before that, while their nervous system is still pretty vigilant and vibrant and able to deal with these things, and then deal with the structure, function, and behavior that might help them back out of it. So, and when you have sleep apnea, the most common things, well, there are a lot of things, but the most common thing you think of is sleepiness. So there's an Epworth sleepiness scale, some 8 or 10 questions that you have to answer to give you an idea. And there are things like, do you fall asleep while you're sitting at a red light? You fall asleep when you're reading a book? You have trouble keeping awake in a theater? Stuff like that. And people that have apnea can fall asleep at the drop of a hat.
Right.
On the other hand, if you are struggling to breathe at night, but doing that successfully, you are going to be fatigued during the day. Fatigue is different. It's a different feeling than sleepiness. In fatigue, there's sort of a muscular weariness, almost a depressive feeling that you just almost, you have trouble making the next move. And so there's another scale that we use called the fatigue severity scale, which just looks at this problem in a little bit different way. People that have upper airway resistance, as you properly called it, feel more fatigued. And there are really a whole host of symptoms in sleep apnea. There's a lot of stress on the heart and the circulatory system. People with apnea are very commonly subject to cardiovascular disease and stroke, that kind of stuff. There's a lot of stress on organs. There's a lot of stress on growth. I should say this. It's not just older people that get apnea. Kids that have large tonsils and adenoids that are corking up the airway will also have apnea. They have to be really big. But in airway resistance, it's a very different symptomatology. It's more like depression. It's general pain. It's things like fibromyalgia and other assorted non-specific pain syndromes or discomfort syndromes. Medicine has struggled to try to characterize these things. Dentistry has been working with pain in the head, like TMJ pain, headaches, neck aches, that sometimes even toothaches that come from referred pain. We've tried to deal with these things through anatomical treatments, like concentrating on the shape, size, function of the temporomandibular joint. But there are other times in history where we just said people that have these kinds of pains are crazy. It's just there's no seeming reason for it. And now we're really putting together the idea that there's a lot of things we've been struggling with as practitioners that are related to poor night's sleep, facial pain, the muscle dysfunction, the grinding and clenching of the teeth. I mean, people will literally destroy their teeth and the fillings that the dentist puts in to repair them because they are clenching and grinding so badly at night that they and why? Because clenching and grinding is a compensatory behavior for not being able to breathe well. If you clench your teeth really hard, it kind of opens the muscles on the back of the throat. There's a pairing of muscles that are antagonistic there, where clenching will open the throat, or it's part of the arousal. You're actually trying to wake yourself up. We know this by watching people in the sleep labs. These arousals happen when you're having trouble.
They'll grind their teeth to try to wake themselves up.
Yeah. I don't know if I would say it exactly that way, but they are grinding themselves. They are grinding their teeth as they are waking up. I'm not sure which one causes which. It's an association that we don't really fully understand yet. But it's clear that we should not be clenching our teeth at night. And we've even demonstrated that the pressure you can put on your teeth at night when you're going through these arousals is 5 times greater than you could ever put on your teeth awake if you try to clench and grind your teeth. Isn't that amazing?
Yeah,
we would never hurt ourselves during the day as badly as we hurt ourselves at night when we're having trouble breathing.
Interesting. So what are some of the, the common remedies that I've talked about a lot, CPAPs, oral appliances to advance your lower jaw. What about uncommon ones, or ones with difficult cases, or ones you think will be more efficacious that, aren't just the gold standard, as they say?
Yeah, the gold. So what's true is that if someone has real sleep apnea, you shouldn't mess around with any other kind of thing, but stabilizing the airway as quickly as you can. Medicine doesn't have a lot to offer in a way. They have CPAP, which in my mind could be used as a good crutch, and but you don't. Medicine will let you stay on it forever. Sleep medicine, they don't always have good. Now they have tried other things. I mean, I have to be fair about it. For a long time, they were cutting tissue out of the nose and throat as a way of opening the airway, and uvulopalate, take sort of like a fat removal, take out the fat pads, reduce the tonsils, the adenoids, cut away some of the uvula, cut away some of the sidewalls, take out the turbinates, or reduce the size of the turbinates. These are all ways of creating more flow. But the long-term studies are showing that many of the breathing problems will return after a while. And it doesn't surprise me, because they're only taking care of one small part of the problem, and that is the anatomy. In my mind, if you're going to do this properly, you really have to address all 3 aspects of the airway: behavior, physiology, and the anatomy. So yes, you do want to make the airway bigger. Even a small amount of size improvement can make a tremendous difference in airflow, right? To meet power. So yes, bringing the jaw forward. In adults, we do that artificially with an appliance that'll jut the jaw forward, that brings the back of the tongue out of the throat. In kids, appropriately, we try to get the bones to grow forward. That's what we were talking about last time. If I can get the jaw bones to grow to their normal, proper size, then not only will the airway be bigger, but there'll be more room for the tongue in the front of the mouth, so it doesn't have to hang out in the back of the mouth. And teaching good breathing behavior is something that we can do, and it's I'm going to say it's harder than you would think, because just breathing deeply or doing meditation or yoga, that's kind of the right thinking, but you can be very relaxed while you're doing a yoga class and do pranayama and all that. But then you get in your car and you're on your way home on the freeway, and the traffic starts again, and your kids call, want to know where dinner is, and so forth. Your breathing is back to where it was. So there is a group now of physiologists and behavioral psychologists that are teaching breathing behavior using a biofeedback tool that measures end-tidal carbon dioxide. That is carbon dioxide at the end of the breath. It's really equivalent to what's in your lungs and in your blood, and is a good measure of how efficiently you're delivering oxygen. So you can use that to pinpoint times when your breathing behavior becomes dysfunctional because it's associated perhaps with some kind of stressor in your life. That could be a physical stressor, a mental stressor, lots of things will trigger an autonomic response in our body, right? You're probably aware of how stressful the modern environment is to us, in that we're in sympathetic mode a lot, and we don't.
What can you do about what can you do about all this? How do you fix your breathing? How do you accomplish any of this?
Yeah, so the biofeedback training with the capnometry, it can be a very successful tool if it helps you become more aware of those times when you're over breathing. And the assumption is if you can tame your breathing during the day, that you will likely breathe better at night. And certainly the obverse is that if you're not breathing well during the day, you can't really expect to be breathing well at night. So sleep is...
Well, I want to ask you more about the capnometry, but what about myofunctional therapy, if you do exercises to try to strengthen your tongue and your throat and things like that?
Yes, exactly. So that's also another approach that works on the physiology, in that when we have muscle patterns that are themselves dysfunctional, which lead to poor jaw growth, that the tongue can often be an interference. The constrictor muscle of the back of the throat can be an interference, and the position of the jaw can be an interference, and the way the hyoid bone sits can be an interference. It becomes this tangled mess of form and function that leads to a trajectory of ill health or poor breathing and poor sleep and so forth. So myofunctional therapy can be really helpful in toning the muscles, getting the tongue where it belongs, up on the palate, out of the back of the throat. Then changing the structure, which is really where I come in, can be important. For children, like I say, I try to help the bones grow properly from the get-go. But there are things you can do for adults to help widen the palate, bring it forward. Sometimes we can use natural processes of bone growth and remodeling to help the bones change. You heard about this when you hosted Ted Belfour some weeks ago. Or, a little more drastically, but also more certainly, you can surgically reshape the jaw bones, effectively dislocating them from the skull, moving them forward away from the back of the throat, and then reattaching them in a way that provides a big, beautiful airway. And frankly, this is probably the most efficacious way of handling these problems that are certainly serious. Not everybody's going to choose to do major facial surgery for that, but if it means adding 10 or 15 or 20 years to your life to help your circulatory and mental function, over those years where it's otherwise going to get beaten up, it's kind of worth it. And I've heard testimony from people who come out of the OR and go, "Oh my God, this is what it feels like to breathe," because for the first time that passage is open. And this is, Richard, I really see this as one of the crucial factors in human society, is that many of the chronic diseases we're suffering are likely linked to this inability to breathe well. Wow. And it's really not received the kind of attention that it needs, because so many of us in medicine and dentistry pay so much attention to the symptoms themselves in our silos of specialty that we miss this big picture. And there is nothing more important than oxygen. It almost sounds silly to say it, because everybody knows you can't go for 3 minutes without oxygen. And yet, who pays attention to it? You figure if you woke up in the morning, you're breathing okay.
But you don't think a lot of these things. I mean, a lot of the best things I've ever learned are, someone could always come along and say, "Oh, that's common sense, that's obvious." But it's okay. There's a lot more beyond the obvious statement that you need air to breathe. That's what we've been talking about for the past hour. So it makes sense. Don't worry.
I say, well, you can run your car on 87 test gas, but it'll run a whole lot better if you're on 94, 98 or whatever.
93, yeah.
And that's what's happening. We're suffering from chronic intermittent hypoxia that doesn't register on a moment-to-moment basis, but over the life of the machine, it wears the parts down.
Well, very good. You get so much to say. That's the problem. We're out of time again, but I just want to give listeners again another call to action. How do they, if they're in your area, what area do you serve, and how can they come see you? And then I want to ask what they can do if they're not in your area physically.
Right. Well, I mentioned this last time, and I will say it again, that no matter where you are, there's a group of like-minded dentists and physicians that are thinking more functionally, that are thinking more holistically about this issue. And you can find a number of them at an organization called the American Academy of Physiologic Medicine and Dentistry. We'll just jot this part down, aapmd.org. And they have a database of practitioners who think like I do. West of Manhattan, in Clifton, my website's alignmind.com. It's a holdover from when I just did the orthodontic piece, but that's how they can find me. And if I attract any practitioners, and this is, in a way, this is my mission, because so many practitioners, especially orthodontists, need to start paying attention to this in a much bigger way, because so many people suffering from them. I am happy to teach them everything I know. I set up a classroom. I can give courses. We have courses for all levels. I bring in speakers and all that, so that you can go back to your practice and start addressing these problems. And that's at learnairwayortho.com.
Okay, very good. Well, Barry, thank you for coming again.
You're welcome. And now I'm a fan. I can't wait to see your next episode.
You're listening to the Future Tech Podcast with Richard Jacobs. Future technologies such as artificial intelligence, stem cells, 3D printing, gene editing, Bitcoin, blockchain, the microbiome, quantum computing, virtual reality, and exploring space are much closer than you might think. In fact, many early versions of these technologies are in play right now, and the companies that are using these technologies are the focus of this podcast. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a thorny medical problem. Remember, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you enjoyed the podcast, please listen, subscribe, like, and tell your friends about it. Thank you.